And what about high ankle sprain? It's a little bit different from lateral ankle sprain. So it involves the ligament between the tibia and fibula, including the anterior inferior tibial fibular ligament and also the syndesmosis. For this kind of injury, it takes more time to return to play. And also you need to look for possible fractures. So Ottawa ankle rule is quite convenient to use. It's a tool to assess whether you will need an X-ray for ankle. So you are going to palpate different area, including lateral malleolus and medial malleolus, and also distance 6 centimeters above it. And two crucial, your bone here is a navicular and the fifth metatarsal base, which is the insertion of tibialis posterior here on navicular and the peroneus brevis on your fifth metatarsal base. And also you need to look at whether the patient could wear bearing for 4 steps in the ER room. If they can't do it, one of the criteria was made, then you may need an X-ray to rule out whether there will be a fracture. And when you're doing an X-ray, sometimes you need a weight-bearing X-ray. And there are several parameters can be used, but for example, this one, we are looking at the overlap between the tibia and fibula. So you are actually looking whether there is a space widening, because high ankle sprain is an injury between these two bones, the tibia and fibula. So the normal overlap will be more than 10 millimeters, but if you got like less than 10 millimeters in it, it's indicated it's a separation. And in high ankle sprain, sometimes you might need surgical intervention if instability was presented despite conservative treatment. And a little bit more about whether we need surgery or not, or in the importance of rehabilitation. So we just talked about stability, and actually we can divide this stability into 3 different components, which is your passive system, including your bone and your ligament. They are non-contractile tissue, and your active system, which are like muscle or tendon. And don't forget, there are some neural components, which is your proprioception. So it's a control system. And in people who got like injury, for example, like ankle sprain, you might torn your ATFL, but simultaneously you might have some muscle strain, and also there are some mechanoreceptor inside your ligament and your muscle, so your control system might be impaired as well. And what if you just do surgery, pure surgery, no rehabilitation? Probably you can fix a little bit your passive system, but you still need time to build up the strength. And if you leave these components, then it wouldn't be a stable joint. And if you look at this figure, what if we do surgery plus rehab? Then it probably, ideally, you'll get a fully stable joint with slightly different percentage. But as everyone knows, not every sport injury needs surgery. For example, like most lateral ankle sprain, they are not indicated for surgical intervention. You only need conservative treatment. And even people don't have ATFL, they can play. Many basketball player or football player, they don't have ATFL because they have already torn it. So a proper rehab, maybe you still can't repair the passive system, but by training these active system and control system, you can use these system to compensate the impairment of your passive system. So this joint is still stable because you can train these 2 components. So for rehabilitation for ankle sprain, first of all, of course, in the initial stage, we need to deal with swelling and pain, and range of motion is very important. For ankle sprain, the most common range of motion deficit is dorsiflexion. And as you can see here in this figure, if you do have dorsiflexion limitation when you're doing a squat, then you might need to use your knee or your hip to compensate the total angle you need. And at this position, you will put more stress on your lower back. So maybe your lower back pain is come from like years ago, you got an ankle sprain. And this is what happens when you got symmetrically dorsiflexion, but what if one leg has a deficit of dorsiflexion and the other leg is still preserved? Then the most common situation is you will use external rotation to compensate the lack of dorsiflexion. So at this circumstances, you got like a torsion of your trunk, and sometimes it will cause some problem around your lower back. So this is a example of regional interdependence. And we really need to address the proprioception. So how do we train your proprioception? We can start from single leg stance. This is the most simple one, but we can kind of modify the difficulty or level of the exercise by closing your eyes, because if you close your eyes, you are purely using your proprioception. And if you want to further challenge your proprioception, you can stand on a unstable surface. And normally I would tell the patient the minimal criteria you can return to the quarter return to play is you can perform a single leg stance with your eyes closed around more than 30 seconds. And there are some functional testing, for example, like Stark excursion tests. So you can use this test and compare the healthy side to the affected side. And ideally, we hope the difference is less than 10%. And braces as needed. So after injury, if you use some ankle brace, some literature support, it will prevent you from secondary or further injury. So return to sport or return to play, it's a very, very crucial issue in sport medicine. And you need to know progression is not only by timing, it's by function actually. So don't use time as an indicator. Like, for example, like, oh, it's already 3 months, so I can do some resistance training. No, you need to see what is the function of your injury part. So return to daily life and return to play, they are totally different. And return to play, you can separate it into two different level. First is return to training, and the other will be return to competition. What is the difference between training and competition? Training is kind of modifiable. You can tell your team member, you can tell your coach, okay, now we should monitor the training load. But in competition, you can't ask your opponent like, oh, this is my first game after my ACL repair, so please don't play too hard. It's not possible. So the devil is in detail. So it's like a butterfly effect. So if you don't manage your ankle sprain well, you got like deficit in your range of motion. Sometimes it might cause further injuries in other body parts. So again, an example for regional interdependence. And now let's go to concussion. So I don't know, like everyone, what is your first impression about concussion? It's a brain CT, whether it's ICH or not, or just rest and go home. But actually, concussion is not only concussion. The latest evidence or the latest consensus statement come from 2016 in Berlin, but actually this year in 2023, the sixth International Consensus Conference for Concussion happens in Amsterdam in October. So next year in 2023, the scientific committee is going to issue 11 different systemic review addressing different topics on sport-related concussion. So I strongly recommend everyone interested in sport medicine to take a look after they release these systematic review. So these are definitions from the 2016 version. So it's a traumatic brain injury induced by biomechanical force with the features of impulsive force transmitted. Okay, the keyword is transmitted to the head. So it doesn't necessarily need to be a direct blow to the head, but you can transmit the force by your neck or by your trunk or even everywhere else in your body. And typically, it results in a rapid onset and short-lived impairment of your neurological function. But sometimes, in some cases, these signs or symptoms are going to last for long. And there's actually no structure disturbance. So it's only purely functional disturbance. But recently, we got like more high-class images, and sometimes you can use functional NIRS or some more progressive image to see whether there is a change. But currently, brain MRI is not indicated in concussion patients. And the symptoms might be prolonged, so be aware of post-concussion syndrome. For the mechanism of injury, we just talked about it. It doesn't need to be a direct blow. So contact force directly to your head is largely absent in concussion. In contrast, actually, it's mostly acceleration force. And you can divide it acceleration force into linear and rotational force. And what accounts more is rotational force. So this is the reason why when you're, like, for example, when they're going to knock out their opponent, they're going to hit on the cheek and their chin and will create a rotational force. So direct impact on your face or on your head, it doesn't necessarily cause a knockout. But if you do it, punch it and make it a rotational force, it's more devastating. And what are the signs and symptoms of concussion? So the symptoms include some somatic, cognitive, and emotional symptoms. So somatic system, including headache or migraine, and sometimes you will have some feeling like you're in a fog and irritability. And physical sign will be transient loss of consciousness, and also some people might develop amnesia. And you might have some balance issues, some behavior changes, for example, being more emotional or more irritable, and sometimes you will have cognitive impairment. And in some cases, you might have some sleeping or sleeping disturbance and even drowsiness. But concussion doesn't only affect your brain, so the diagnosis should be based on history, clinical presentation, and most important of all is your physician assessment. And there are some commonly being affected systems, for example, your vestibular system. So that's why your balance got impaired after concussion, and your oculomotor system, and your cervical spine, so cervicogenic headache, and you might get some issue of balance or even vision or memory. So when we are doing an assessment, currently the most widely used and available tool is SCAT-5, the Sport Concussion Assessment Tool, the 5th edition. And next year, they are going to issue the SCAT-6 and also the SCOUT-6. SCOUT is SCOAT. It refers to office assessment. So let's take a little bit look about the SCAT-5. So it's a standardized tool, but it's designed for physician or licensed healthcare professionals. So it's not designed for general population, and you should not provide SCAT-5 less than 10 minutes. Okay, so you need at least 10 minutes to perform the SCAT-5. And it's used for a patient above 13 years old. So if you're doing assessment for for children, you're going to use a children version, the child SCAT-5. And the SCAT-5 itself cannot use isolatedly to make or exclude the diagnosis of concussion. So it's just an assessment tool. It's not a diagnostic tool. So first is an immediate or on-field assessment. So we are going to look at whether there are red flags for more severe brain injury, for example, seizure, neck pain, double vision, or vomiting, and some observable sign, for example, like there are some facial injury. And we will ask meta question to make sure the orientation is good to the patient, and also Glasgow Coma Scale and cervical spine assessment to rule out more severe spinal cord injury, the possibility of spinal cord injury. And these are the office or off-field assessments. So first of all, we are going to take a background, the history taking of the background of the athlete, because as everyone knows, prior sport injury is the most powerful predictors of future sport injury. And there are a symptom evaluation sheet, which is composed of 22 different questions with the highest score of 6. So this is actually quite useful. So if you've got a baseline of the athlete, and you can compare it after injury, and you can also use it as a following tool to see whether there is clinical progression. And for cognitive screening, we can use we can see what is whether the patient is oriented, and we can use the vocabulary bank to test the immediate memory, and also digit backwards and months in reverse order. And neurological screen, we are going to use balance examination. And then the last one will be delay recall after 5 minutes, and you can use the vocabulary bank you used before, and to ask the patient or the athlete to repeat as much as possible and to record it on your SCAT-5 sheet. And finally, you'll make a decision. But be careful, scoring of the SCAT-5 should not be used as a standalone method. So again, the diagnosis of concussion should based on your clinical expertise, and SCAT-5 is only an assessment tool. And once you got the diagnosis of a concussion, remember, it is prohibited for the athlete to go back on court on the same day. Other than SCAT-5, there are many different assessment tools. For example, you can do Buffalo concussion treadmill test, you can do Vollmer's test, and you can use these fancy tools to assess your cervical proprioception. And this is a sensory organization test. And there are also some commercially available concussion assessment software, for example, like Impact. And for rehabilitation, first of all, you need to physically and mentally rest for at least 24 hours or to 48 hours. It depends on your symptom severity, and following by a graduate return to play protocol. And you need to stay at each stage at least 24 hours for symptom free. And some guidelines might propose for the children, you will need to stay at least 48 hours. So it really depends on different guidelines, but 24 hours is the minimum. And then you need to deal with the affected system. So they divided into 6 stages of the graduate RTS protocol. So first you are going to do symptom limited activity, followed by some light aerobic exercise and sport-specific and non-contact drills, then full contact practice, and finally return to sport. So in minimum, it usually takes you about 1 week to return to sport. So the next time when you encounter some concussed athlete, remember to tell them not to go back to sport within 7 days. And here is a protocol for aerobic exercise after Buffalo concussion test. So in brief, Buffalo concussion test is using aerobic exercise to challenge your autonomic system. So we will perform a exercise testing and monitor the heart rate, and we will see when the symptoms will be provoked and set it as a target heart rate. And we are going to use 80 to 90% of the target heart rate to train the athlete, like for 5 to 6 days per week, and then we will repeat the Buffalo test again to get a new target heart rate. And we are going to see whether the athlete can recover to the 80% or at least 90%, actually in the athlete, at least 90% of the maximal predicted heart rate without symptom provocation. And there are also some potential serious consequences, which is chronic traumatic encephalopathy. And this is a film in Hollywood. It's from Will Smith, The Concussion. I highly recommended everyone to have a look. It's a story about Dr. Omalu, who initially discovered chronic traumatic encephalopathy in the NFL players. And sometimes there are some even more serious consequences. For example, second impact syndrome. It's not wildly, or it's still like quite debatable, but there are some evidence suggests after the first time of your head injury, if you didn't manage it well and you let a patient or you let the athlete go back to court too quick, then after a second impact, although the second impact is really, really light, for example, just shoulder bump into shoulder, then there will be devastating consequences. And also, concussion is not only concussion, so the risk of musculoskeletal injury actually increase after concussive episode. So these are two literature talking about this topic.